I thought this is 1:30 or so in the afternoon, and after lunch, we're probably all of us a bit drowsy if we've had lunch. So what I've done is tried to put lots of pictures into the talk rather than a lot of talk. Okay. Epilepsy, as you know, is one of the most common neurological disorders in childhood. The title of my talk is Children and Epilepsy, or Epilepsy and Children, and it's going to be a bit of a potpourri of a talk. I'm not going to talk about epilepsy surgery. The highest incidence of seizures across the lifespan is actually when you're born. The first 4 weeks of life, the risk of seizures is much higher than at any other time in your life. And also in children, it's higher than in most adults. And then after the age of about 50 or 60, it starts increasing again. The incidence depends on which part of the world you're coming from. It varies from...
Sorry, it's very soft. Sorry. Speak.
It varies from 33, does it sound okay? Yeah, to about 124 per 100,000 children. And we now know that EEG, and in most situations, neuroimaging with MRI or sometimes some other studies, is very important to determine the epilepsy syndrome. If you have certain kinds of epilepsy, you may not need neuroimaging, but most of the time, especially if you're not responding to the first or second drug, you do need to get both those scans done. The genetic testing is becoming very important. Every year, there are that many more genes that we see associated with different kinds of epilepsy. But still, the numbers who have a specific gene variant that could account for their epilepsy is very small. But we are learning more and more, and that area is progressing very rapidly. We know most people who have epilepsy don't have any other problems, but there's a much higher incidence of having trouble with cognition, with day-to-day living, with memory, with headaches, with depression, with mood problems, sleep disturbances. And in the past, we've all been probably just focused on the seizures themselves rather than everything else. But for your quality of life, that everything else is just as much important as getting control of your seizures. And about 20 to 30% of children with epilepsy are at risk for all these comorbidities as well. Okay. There are lots of things that have advanced. We now have, the EEG has been there for a long time, since the 50s. However, we now look at different things on the EEG than we used to before. Even when you look at it, you use different filters. You look for activity which is very fast and activity which is very slow, whereas we used to look at between, say, 0.5 to somewhere from about 1 hertz to about 25, 30 hertz. We now look in the thousands and to much less than 0 as well. When we're not all situations do we need to, but we can look at different frequencies and different things. So that's helped us understand the process much better. And also, we have better treatments for infections which led to epilepsy and bad seizures. So lots of advances have been made in different fields that have made things much better. And neurogenetic causes, neurometabolic causes have also helped us sometimes target therapy to that particular gene or that particular metabolic problem that's causing the epilepsy. Now, one of the things about epilepsy in children, we all know, all of us who have children know they do funny things all the time, and sometimes they do the same funny thing again and again, or something unusual again and again, and it can look like seizures, especially if motor phenomena are involved. And when they've looked at children who've been diagnosed as seizures, if you're not careful, what happens is that about 25% the diagnosis of seizures is incorrect. So it's important to diagnose epilepsy, but it's also important not to incorrectly diagnose epilepsy when it is not, because then you're going to go treat with things that are not necessary, and then give more medications because it's not working. But the prime problem might have been that the diagnosis is you have to look for something else. And it can be quite challenging in children. And sometimes children with epilepsy can also have non-epileptic events that can mimic seizures. And so making that distinction is very important. And it's worth spending time making that distinction, because obviously what you need to do next is different for the two situations. And one of the things that also even children who have the first seizure need counseling for safety regarding around the possibility of another seizure. And that's something in pediatrics is being emphasized quite a bit in pediatric neurology and general pediatrics, so that you talk about it with the first seizure. Now, and again, look for the other things that you might be associated with epilepsy. And current guidelines suggest that you have a referral to a pediatric epilepsy center if your child has seizures before the age of 2, or the child has drug-resistant epilepsy, meaning 2 or more medications have not worked, or has an epileptic encephalopathy, or the reason for the epilepsy may need targeted therapy. And so that's something in most parts of the world we're not able to do, but it's something that we should aim to do. And we certainly in Australia, we should be doing it. Now, I'm going to switch a little. So we used to think of epilepsy as coming from one particular area of the brain if you called it focal epilepsy. However, what we know is that it's not just that area, it's a network that's involved in most epilepsies. So you have atypical activity where the seizure starts from, but it also influences the activity in large populations of neurons that are not the seizure focus. And this complex interaction probably accounts for different manifestations, but also for the comorbidities that you can see when you have epilepsy. And better understanding of this is probably make us understand how to treat the whole phenomena much better. And there's a lot of things that I've looked at help us understand what we call the brain connectome is. And this is from clinical histories and from examinations and from EEGs and MRIs. And now people are using a lot of artificial intelligence to sort of help us understand networks much better, and also help maybe predict who's going to have difficulties and who is not, so that you can even counsel better and anticipate and put in early interventional services before you have the problem, if you think there's a high risk of the problem. And so, see, when you talk about the operational definition of a seizure, according to the International League Against Epilepsy, and we all use these definitions now, the seizures are divided into those, like either it's a focal epilepsy or a generalized epilepsy. And I think in the focal epilepsy, you start in one place and you spread to the other areas. But the more work we're seeing with epilepsy networks, the more thinking maybe we're not quite right in thinking that way, because even the generalized seizures like absences probably start somewhere very small in a focus and quickly involve lots of circuits, the network, so that they become generalized very fast. But this is just something people are doing a lot of work on to see if that definition is really valid or not. Again, I'm digressing a little bit, but I think to understand epilepsy, it's worthwhile thinking of lots of different things. And this is the classification of epilepsies in babies, neonates. It is different from the classification that is used for children and adults. And what this is, and this for the first time, what has also been categorized and classified, is that you can have seizures that are only on an EEG, that you don't have to see anything physically. And this, in neonates with seizures, most seizures are symptomatic. It's because of something else. And the seizures, most of them are only on EEG. And if you do prolonged studies, you find up to 80% of seizures are only on EEG. And in babies, if you have lots of EEG seizures, even if you don't have clinical seizures, the outcome for neurodevelopment is influenced, or it is worse if you have lots of electrographic only seizures. So the concept of epileptic encephalopathies also is related to this. So if you have a lot of EEG epileptiform activity, irrespective of you may have lots of seizures, but we may not have lots of clinical seizures. But just the EEG epileptiform activity can influence your cognition, your development if you're a child, and can influence your quality of life. And so electroclinical seizures are the other type of seizures in babies that you can see, but they're much less frequent in the first few days of life than only seizures on the EEG. So, and then the parallel streams is what we all now try and think of every time you see someone with epilepsy or thinking of someone, because you think, what is the seizure type? What is the seizure syndrome? And what is the etiology? It may be multiple etiologies. You may have tuberous sclerosis. You may have a gene defect, which is the cause of the tuberous sclerosis. And you can have a cortical dysplasia that's actually causing the seizures with the tuberous sclerosis gene. But if you don't know, now it's imperative that we think of it each time to try and see, because there's so many advances, and we may be able to find out why today, which we couldn't 10 years ago. And the other thing is to think of comorbidities. And these may change with time, depending on how old you are, what you're doing, etc. So that's important to remember. Now I'm going to go back to babies, because I think it's easier to understand epileptogenesis in a baby than sometimes. And so if you look at babies, as I said, I put lots of pictures into the talk so that it's sort of, you can just look at that. They're fairly good illustrations. And this is the hypoxic ischemic encephalopathy, where there's been reduction in blood flow. Oxygen to the brain is one of the most common causes for seizures in babies. And the other causes are like strokes, or you can have the brain, the brain may be formed differently and may have a malformation, could be genetic causes, metabolic causes, and sometimes in some parts of the world, infections are a big cause for seizures as well. Now, when you think of the concept of epileptogenesis, of the babies who have seizures in the neonatal period, only about 20 to 30% will go on to have epilepsy in the long run. Why do those 20 to 30% have epilepsy, and why do the rest don't have epilepsy in the long run? And that's one of the areas. And the concept applies to, like, you have a stroke, but you have epilepsy starts later, or you have a head injury and epilepsy starts later. That time frame in between where something is happening, could we influence that to prevent the epilepsy occurring, or even making it a milder epilepsy rather than a more severe epilepsy, is where there's a huge amount of work being done across the world. So if you look at neonatal seizures, so as we said, most of them, as you saw on that picture as well, they are acute symptomatic seizures because of either HIE, or because sugar is low, or electrolytes are abnormal. And some babies then get so much injury from that acute seizures itself and the cause that they go on to have seizures all the time straight, they continue to have seizures. But there's about 20-30% will stop within a few days, but then will have seizures afterwards, after a prolonged period of being no seizures, maybe months, maybe years sometimes. And so can we do something there to prevent that, is some of where a lot of work is being done now. Now, this is just to give you a thing. This is one of my colleagues who used to work on basic science networks. And so this is injecting a single cell in the brain. There are lots of cells, but this was a cortical neuron. And this is one cell, and each cell has tens of thousands of connections. It receives impulses from other cells, and it sends impulses to other cells. And the brain has got billions of cells. And so if each cell has got tens of thousands of connections, you can see how each area can influence a lot of other areas, because each of those will project to other areas of the brain, or to your motor system, or your sen. And now, so again, coming back to the babies, but this can apply to any period where there's injury first and then epilepsy develops later or gets worse later, is this period of time when there's inflammation, scarring, and then the brain, the connections between the cells change. And this is that latent period where people don't know what, but there's huge amounts of work being done to try and prevent then the cells become hyperexcitable and producing seizures. And people have looked at the time of the injury, what all can we do? Can we give good anticonvulsants to try and prevent lots of seizures? Because you have more seizures, more likely to have injury than if you have few seizures. And then, what can you do here? Can you use anti-inflammatory agents? Can you use neuroprotective agents? Can you use erythropoietin? Can you use magnesium? Can you use compounds that people are developing? That's where a lot of research is going across the world. Okay. Now, in clinical practice, this has been applied to epilepsy and tuberous sclerosis in babies. We now pick up babies with tuberous sclerosis because they may have cardiac rhabdomyomas, and when they get antenatal ultrasounds, they're picking up the rhabdomyomas. So then, because it's got a high association with TSC, we image the brain when the baby is born. And I don't know how many of you are familiar with it, but 80 to 95% of people with tuberous sclerosis will have epilepsy. And it often presents early in childhood, often is difficult to treat. And therefore, if you look at children with infantile spasms or West syndrome, the single most common cause is still tuberous sclerosis. There are lots of causes for it, but this is one of the more common causes. And if you have early onset spasms, early onset seizures, you're at a higher risk of autism, you're higher risk for intellectual disability. So if you can prevent that or even delay things, it might be better. So a lot of work people have worked on trying to see if, and what we know from babies is that the EEGs often become abnormal before the seizures start. So you can pick things on the EEG before seizures start. So can we do something? And then animal studies suggested that we could. And then, so people sort of started thinking more. And I'm just going to give you an illustration of a baby who was prenatally diagnosed with cardiac rhabdomyomas. I'll show you the MRI in a second, showed multiple tubers and did show that this baby had tuberous sclerosis when the baby was born. They had a first EEG in the neonatal period, and we now, the guidelines are that we should be doing EEGs even if the baby is otherwise fine in the neonatal period. And the first EEG was fine, the baby examined well. This is the MRI, and there are tubers. Those are the tubers that you can see there. So this baby had multiple tubers, and subsequently had a gene test which confirmed it. But with cardiac rhabdomyomas and that sort of imaging, you're fairly certain that that's the likely diagnosis. So then the next had an EEG at 3 months of age. On this EEG, there's just these few little blips here. Can you see that? That's a spike. That's just, and this is all normal looking EEG, but just that little blip there and one little blip there. There's a little blip there. And so this is just some left frontal spikes. Now, current guidelines actually say you may consider using a drug called vigabatrin, which has visual field effects as a possible side effect very early. And some centers would start at this stage. But we hadn't seen this baby, so we called the pediatrician and we said, why don't you start something and provide them with the literature in this area? And so this was started a medication. Baby was fine, was not having any seizures. There was nothing wrong with the baby they could find. But the next EEG was okay. Then so this is what happened. So started on a medication. But then the EEG at 4 months, I don't know, you have to take my word for it, is showing, sort of few more, but okay, not too bad. And the EEG at 5 months was definitely, if I do that, can you see it? Yeah. Both sides? No. Pointer doesn't really. Okay, I'll just do. There's a lot more epileptiform discharges now. 1, 2, some over there, and quite a run of them. Baby's no seizures still. Baby's fine. There's nothing that the parents pick that's in any way different. So we actually talked a lot because it's difficult to use a drug that has a 20 to 30% incidence of visual field effects, because babies who show this, 90% are likely to have seizures and bad seizures, but there's some who won't. And right now, we don't know how to make that difference. So, so we did start vigabatrin on this baby, and the babies continued to do well. So the question is, what are we doing? treating this baby with vigabatrin, a potential medication that can have a serious side effect. And so what this is, what happens, as I said, you can have, people started thinking, can we prevent infantile spasms by treating if we see those epileptiform discharges? And what some studies have suggested, there's a prevention of epilepsy in infants with TSC study called the EpiStop study, which suggests that if you use vigabatrin when you see those discharges, even before seizures, that you get the risk of clinical seizures, drug-resistant epilepsy, and infantile spasms reduces. So that's that's an exciting area, but an area that's not simple to make decisions on, and we have to make decisions together in these sort of situations. Okay, so current recommendations are, you can propagate this, is that infants with TSC or who are picked up with TSC antenatally should have EEGs every 4 weeks for the first 6 months. It's very difficult for us to do every 4 weeks, so we're trying our best to do it at least every 2 months, if not every 4 weeks. And that's true for most parts of Australia now. And every 6 weeks for the next 6 to 12 months, and after that, every 8 weeks in the second year of life. It's very difficult to do this. I mean, time can, amount of effort this needs, but it's a new recommendation now. Now, when I'm going back to harp on seizures in the neonates, we also, like we talked about, that's the biggest group. But then you can have seizures because of, you can have seizures. Metabolic disorders are quite uncommon. But, if a sick baby, if you've got infection or something, a little bit of low sugar, hypoglycemia, or the sodium being up or down is not uncommon. Those are metabolic perturbances, but they are also important because they can worsen seizures. But you can have babies which have self-limiting epilepsies. We used to call them the benign familial neonatal seizures or benign familial neonatal and infantile seizures. And then there are also epilepsies that are not good to have, called the developmental and epileptic encephalopathies, which start in the neonatal period or in early infancies. That's a small percentage, probably about 15%. But you have to be aware of them because now, occasionally, in very, very few, we actually have specific therapy you can use, so it's important to be aware of it. And these are just the self-limiting epilepsies that present in the neonatal period, which now, also I thought I'll put the slide up because if you start reading the literature, the terminology has changed. All those seizures we used to call benign focal epilepsy of childhood, benign focal neonatal seizures, now are being called self-resolving, self-limited neonatal epilepsy, self-limited epilepsy with centrotemporal spikes. So if you see that, then you know that they're talking about all those which coming with self-limited was what we used to call the benign focal epilepsy of childhood, benign neonatal epilepsy and things. But also in babies, epilepsies can start. That can be because of developmental and epileptic encephalopathy. Who understands this concept? If you hear a developmental encephalopathy, what do you think it means? DEE. This is going to be branded around for lots of children's epilepsies, especially, and the more difficult epilepsies in childhood. Does anyone want to have a go as to what you think? That we've talked about epileptic encephalopathies when seizures or an EEG that shows a lot of epileptiform activity contribute to making cognition worse or not allowing you to develop. So you can have developmental regression, you can stagnate developmentally. So that is an epileptic encephalopathy because of the epilepsy. But a lot of things, for example, you would say Dravet syndrome, which is often associated with the sodium channel mutation, can have other mutations, but most commonly with that, is often an epileptic encephalopathy. But also, you can have children in whom you control seizures, the EEG looks reasonably okay, but development may be a problem. Because the sodium channel mutations that's causing the epilepsy is also causing other parts of the networks or the brain neuronal networks not to work properly. And therefore, you can get a developmental encephalopathy as well. So in the next 10 years, and most of the literature is going to have lots of these words. So I put in slides where it sort of tells a little bit about the different new words that are coming or new phrases that are being used in the concept of epilepsy. And then there are some etiology-specific syndromes, for example, CDKL5 mutations, which is can be a little bit like Rett, but not the same, can present in the neonatal period or early infancy with seizures. Then, and why is it important? Targeted therapy. Some of the more common, where we know which gene is causing it, it's called a KCNTN1 mutation, where in babies causes seizures from one side, and the other side goes from side to side. They're called focal migratory seizures. They have, they may respond to quinidine. Not all of them do, but it just seems for that particular epilepsy, it seems to be useful. So we're getting more and more small things like that. So that is very important. And if you have for example, if you have some metabolic disorders, a ketogenic diet is the best thing to go, even if in a baby. So it's important to be aware of it. Now, this is what probably most of you are familiar with. This is the ILA classification that we are using for children and adults across the world now. So it's again has got the three streams: seizure types, epilepsy type, epilepsy syndrome. Etiology is why it is, and it can be multiple etiologies and comorbidities. And it is imperative that we all think of that, saying at each time we're assessing yourself or somebody else with epilepsy, that we think, do we know the cause? Do we know what else is happening? What comorbidity can we do something about? And if we haven't classified it, to try and classify it better. Now, this is again another picture, colorful and nice, from Epilepsy this year. That is, again, just classifies the epilepsies into the genetic generalized epilepsy. That term, about a few years ago, they called all the other, what we used to call the idiopathic epilepsies. They wanted the term changed to call it genetic generalized, genetic epilepsies, because we think it's probably related to genes. But in most of them, we don't know what the genes are. And they're not simple, they're not single genes, they're multifactorial. So now it's again changed because, and also when you call something a GG, a childhood absence epilepsy, there's a lot of implications of it being familial, and in some parts of the world, it resulted in people not being able to get married because you had the term genetic attached to it. So now people are the idiopathic generalized epilepsies, the ones we don't know that much about genes. We know there are associations and stuff. And these epilepsies are the childhood absence epilepsy, the juvenile absence epilepsy, the epilepsy with generalized tonic-clonic seizures, and this is often starts more in adults, and the juvenile myoclonic epilepsy, which starts in teenage years usually, and also goes on. Seizures often, people with JME often have to be on medications long term. That in quite a few, it doesn't remit. And then also presenting in childhood, if you have epilepsy with eyelid myoclonia, myoclonic absences, these sort of overlap with the more difficult epilepsies. Some do very well, some have more difficulties. And then these are the epileptic encephalopathies, or the developmental and epileptic encephalopathies. These are all generalized seizures, but and some of them, and there are several genes that are associated with some of them. So it's a spectrum a lot, and sometimes when you first start with seizures in childhood, it's often difficult to predict someone with epilepsy with eyelid myoclonia, whether they're going to be very easy and get well controlled, or are they going to evolve to having a more difficult epilepsy. And so now, the generalized epilepsies constitute about 20 to 30%. Most epilepsies are focal epilepsies as we understand it today. And about 2/3 are responsive to medications, but the rest may be difficult. This is a EEG signature of a typical generalized epilepsy. So this is a child with an absence. This is normal EEG on the left side of your screen, and then you see this discharge, this high amplitude spike and slow wave discharge when the child has a typical absence seizure. And Now, again, these are the different kinds of syndromes that are used, and there's a generalized epilepsy syndromes, but we're already realizing there's a lot of overlap because some of the generalized epilepsy syndromes have focal seizures along with them as well. Now, these are the ones for those of you who have children and have been diagnosed initially to have benign focal epilepsy of childhood. It is now called with centrotemporal spikes or with occipital spikes. In the early age group, it is now called self-limited epilepsy with autonomic seizures. Or this is the benign focal epilepsy with centrotemporal spikes or Rolandic epilepsy. It's now called SLEX. And the occipital epilepsy, which starts in the first 10 years of life, but towards the 5 to 10 years of age, it's now called COVE, or childhood occipital visual epilepsy, and that's and then there's photosensitive occipital lobe epilepsy called POLE. So this is just so you know when you read things that what they stand for. And then there is EEG. When you have a child with, say, SELECT, which is we used to call benign focal epilepsy with centrotemporal spikes. When you look at the EEG shows some spikes in the wake state, but in sleep it becomes much more. So that's sleep activation of the epileptiform activity. But that can be to different extents. And when you just see a thing, you may not be able to say how, just because you see a lot of spikes doesn't necessarily mean it's going to be difficult or there are going to be any problems. It could be a relatively benign or self-limiting epilepsy. But sometimes the child could present with what looks just like that, but then they start having periods of difficulty with cognition, behavior, motor features, autistic features, and sometimes it fluctuates and they're fine, but may have brief periods, but sometimes they go on to have what is now like a developmental and epileptic encephalopathy, which is called things like Landau-Kleffner syndrome or epileptic encephalopathy with status epilepticus in sleep, because it's like on the EEG, it looks like it's continuously present in your slow wave sleep. And again, these are epilepsies that start across all age groups. So babies, children, adults, when they start, what they start with. And the new things that I'm not sure if you're aware, is something called FIRS, which is febrile infection-related epilepsy syndrome, which we still don't understand very well. And I wasn't expecting that thing about Hannah here, but Hannah has a very rare type of rare syndrome as well. And so we're learning more about all these different syndromes, and there's a lot of, the future looks better than, than what we've had so far. Okay. The other thing, like, genetics, and now the next 5 to 10 years, you're going to read lots about genetics in epilepsy. But it's still, we only know what gene it is in a very small number of people. But what we do know is that a single gene variant may be associated with multiple epilepsy phenotypes. Like you could have a sodium channel variant, you could have 1 or 2 febrile seizures. You could have a Dravet syndrome-like picture where you get difficult seizures and cognitive and developmental problems. But also the other way around, where an epilepsy phenotype could be caused by multiple gene types. So you could have early infantile focal seizures, which are migrating in babies, and you can have the KCNTN1 mutation that we talked about, but you could have BRAT mutation or some other mutations. But when you see the person clinically, they look the same as somebody with the other gene. So it's much complex, but it is quite fascinating. How am I going for time?
Brilliant. You just keep talking. It's all good.
Should I continue or should? Your flattery doesn't get you anywhere.
That practicing for the last half an hour, stuck it up all day. Epileptologist. See, I've got it out twice now.
Okay, and then I just thought I don't know if I didn't see anything saying new drugs on the program today, so I just thought I'd put in something about the new medications. That this is 30% are difficult to treat, and you don't get control with all the drugs that we have. And one of the things, again, when we talk about epilepsy, is that we used to call them anti-epileptic drugs. We've now changed to calling them anti-seizure medications. More because most of the drugs are like giving Panadol for fever. They stop the seizure or control the seizure. They're not influencing that process that we talked about, the epileptogenesis or the epileptic process. Some drugs do, and there's a lot of work trying to see which are the drugs that are both anti-seizure and anti-epileptogenic, but we know all the drugs we use are anti-seizure. So we now call them all ASMs or anti-seizure medications. Then basically they either reduce the level of excitability or increase the level of inhibition, so that the balance, you try and restore the balance that causes seizures where there's too much excitation. And the disease-modifying interventions are the ones that either delay the onset because or they stop the process, which leads to bad seizures, or at least make it better than it was. And one of those is like maybe vigabatrin for tuberous sclerosis starting early, but sometimes it's like people are looking at anti-inflammatories, if they could do that, and lots of other drugs that could maybe modify the disease. Treatment, there's a whole list of medications that we've been using for decades now, and there are some new medications, and medications are important. It is boring to listen to talks about medications because it's like a list of, how do they work, how long what's their half-life, and so you should look up, if you're using a medication, look that one up at that time so that it makes sense and you're aware of possible interactions with other things and what possible side effects. Also very important to remember is that in most neurological trials, there is a placebo effect with whatever you use. So there is, when you have controlled trials where one person gets, the efficacy in the placebo trials is about 30%. And so this is true across most medications. But there's also a nocebo effect in that when you hear this medication may have this side effect, you see those side effects in the placebo arm of the trial as well. Because you're anticipating that side effect. So all the trials, when they say, oh, this is fantastic, all of us are like that. When we try something, we want it to work. So we're also hoping, yes, it's good. But so that's why large studies are important. Now, the new options in childhood epilepsy, but also in epilepsy across ages, is the anti-seizure medications and maybe anti-epileptic medications, that some of them are and some of them are being developed. And then people are looking at novel medications with anti-seizure effects, like some of medications that were used for disease-modifying drugs in multiple sclerosis are being trialed for epilepsy, because you think inflammation may have a role in it. Then, so that's an immunomodulation. And then seizure-responsive brain stimulation. I don't know if Mark Cook spoke about that this morning. Just touched upon it, yeah. Their center has done a lot of work in that area, and probably one of the most advanced centers in Australia for it. And then non-invasive brain stimulation. Again, that's very much in its infancy, and we don't know exactly what role it will have in helping with epilepsy. Now, lacosamide's been there for a long time now, relatively long time. It works through the sodium channel. And it was initially used for focal seizures, but we now know it's also useful for generalized seizures. So it can be used for almost any seizure type, but it's more convulsive seizures. Definitely there's lots of data that it's useful. With regard to absences and things, the data is still coming. There's not that, except in mixed epilepsies, there's no straightforward trial with just absent seizures. The perampanel, again, it's a non-competitive antagonist of AMPA receptor and glutamate receptor, so it reduces the level of excitation. And again, it's been shown to be they're very good. They started off with showing good studies showing that it's useful for focal seizures, but now we know that it's also useful for generalized seizures. Brivaracetam, the exact mechanism is unknown, but it's probably related to synaptic vesicular protein, the SP2 proteins, and I think of it as next generation levetiracetam or Keppra that many people are familiar with, but it's particularly useful if you've had if someone has behavior side effects with Keppra to try, but is good for seizures to try brivaracetam. But there's also data that sometimes when levetiracetam doesn't work, brivaracetam might work. Retigabine is a medication that, again, there's a lesson to learn from that drug. Felbamate was a drug that came maybe in the 80s. It was a very good drug. But after it was marketed, people found there was a much higher incidence of severe liver toxicity. And so the drug was withdrawn. Retigabine is a drug that also works on the potassium channel and was shown to be quite good for focal seizures, but then it also has some from retinal toxicity, so that's also very difficult. I don't think you can get it anymore. Though we all like to think of something new, want to jump onto it, we have to be careful because we don't know all the possible adverse effects, and sometimes only when it's being used in the quite freely that you learn about the rare adverse effects. Rufinamide, it also works through sort of the sodium channel, and it can be useful for it was first thing for tonic seizures in Lennox-Gastaut, but it can help tonic seizures in other epilepsy syndromes as well. And now there's some data emerging it might be useful for tonic-clonic seizures as well. I'm not going to talk about this plant.
Have you smoked any of that?
No. There's tolerability. That's a boring talk. So it's very important to know. But if anyone wants to, please get that article. It's a good detailed summary of the tolerability of or the many anti-seizure medications we do use. It is very difficult to take when you just go one after the other. Epilepsy surgery, I'm just going to, in small number of people with epilepsy who have focal epilepsy, and epilepsy surgery can be very effective. And so it's important to consider it early to see if it's a possibility. And requires quite a lot of workup because you have to be very careful. Ketogenic diet, again, very useful in some, and it's particularly important if you have the glucose transporter deficiency disorder, which is the reason for the epilepsy, because that is the only thing almost that would work. But it's useful for some of the mitochondrial disorders, but also useful for almost any epilepsy in some people. And so it's worth keeping in mind. The modified Atkins diet is much easier to use than the straightforward ketogenic diet, but it is worth keeping in mind. Did I go backwards there? Yes. Then there are, there are specific gene mutations. You can have targeted therapy. For example, in Dravet syndrome, we use tirapentol, which is a syndrome-specific medication that helps for that, but might also help in other epilepsies, but not as effective as for this. Fenfluramine is very good for Dravet syndrome, at least the literature says. We haven't been able to lay our hands on any fenfluramine yet, but it is like a specific medication for Dravet syndrome that the studies from other parts of the world show that could be very effective. The vagal nerve stimulator is being used. I mean, I keep saying Dr. Peter Walsh from our department was the first person to introduce VNS for children with epilepsy in Australia. And we now have an experience of more than 50 children. It's useful in some. It's still difficult to predict who it will work in. And overall, just sort of rounding it off, I think 50% of people, it produces a 50% reduction in seizures. Figures in different studies vary. Some are show much better, some are not as good. But I think if you pool the data around that is where it is effective. Corpus callosotomy, again, some centers go for corpus callosotomy if there are lots of drop seizures first. We tend to go for VNS first and then corpus callosotomy if VNS doesn't work. Okay, this is the last slide. I think this was just to say that epilepsy is, there are people across the world who have this problem, and depending on which part the problems faced or the comorbidities vary. Stigma of epilepsy is still a big problem in many parts of the world. And it's important that in this day and age we are able to share what if somebody does somewhere else and avail. What they found is available to us, what we find is available to them. And the net has really opened up what we can read and what we can talk about. So just to say, we need to continue to work to improve services for epilepsy. Thank you.
Professor Nagarajan.